Good afternoon, everyone. Welcome to our weekly CEO desktop chat, where we will provide you an update on important topics that are taking place across the organization, including our preparation for COVID-19 and other issues facing the system. We have a panelist here who will help support answering the questions that you will pose. As a reminder, there is a Q&A icon at the bottom of the screen. Please make sure to click on that icon, write your question in, and we will try to get to as many of your questions as we can this afternoon. So we'd like to have our panelists introduce themselves. I am Terry Lightfoot, Director of Public Affairs and Community Engagement here for Alameda Health System. Why don't we give Valerie the privilege of being the newcomer to the panel, first opportunity to introduce herself.
Thank you, Terry. I am Valerie Ng. I'm the Laboratory Director of all the clinical laboratories.
Hi, I'm Felicia Torner-Benny, Associate Chief Medical Officer.
Janet McInnes, Chief Nurse Exec, Chief Administrative Officer.
Hi there, good afternoon. Tanvir Hussain, Chief Quality Officer.
Paula Fabaria, the Chief Administrative Officer for Ambulatory Services.
I'm Tony Redmond, the Chief Human Resources Officer.
All right, with that, we will turn it over to our CEO, Delvecchio Family, to start his remarks, and we will continue on with the chat. Delvecchio?
Thank you, Terry, and thank you to my colleagues for joining us today. Really excited about to have you all here in the dialogue we're going to have. Also excited, obviously, as always, to have everyone here who joins us for these weekly chats. I really wanted to share that it's been great and being able to connect with everyone via these desktop chats. Especially appreciate being able to respond to your questions and your concerns. You know, transparent communication is critical, and I hope that these chats are serving that purpose for you. Alameda County, like many of our neighboring counties, is seeing an increase in COVID-19 cases. Not as much as other parts of California, though statewide, that number is actually growing in some ways in concerning ways. It's important that we all recognize how critical it is for us to adhere to our guidelines set forth by health authorities and by infection prevention departments and our leadership here at AHS. We truly are essential workers, and our community is counting on us to be here when they need us. I thank you all for all that you do to remain healthy and to keep our patients safe. I actually don't have any shout outs this week, so I'm gonna make an appeal to you all. Email me and let me know if you've seen someone doing some outstanding work that you want me to shout out. Obviously, you're all doing that, but any special recognitions, I'm more than happy to offer during these calls. Now, there are a couple of things I want to talk about before we get to our Q&A. As has been the case in the past couple of weeks, we've been continuing to let you know what's going on with the pandemic and our response to the pandemic and our experience as far as an organization. But increasingly, we've been adding other topics too, as we want to use this as a forum to keep you aware of latest things going on in the organization as well. So today I'll start and talk to you a little bit about a recent report that many of you may have seen or you may see soon that came out from the Alameda County Civil Grand Jury. This was a report specifically about Alameda Health System, which happens from time to time if the grand jury chooses us as a topic of further exploration. I'll talk to you a little bit about the status of our budget and where things are right now. And then we'll go back into our traditional discussion topics around restoration, around masking and screening, reminders for that, and testing. And as always, I'll wrap up at the end with some pointers and reminders about self-care and wellness for you. Okay, so starting at the top, the Civil Grand Jury. So Alameda County Civil Grand Jury released this week their report. This is an annual report that they do, and as I mentioned, some years they will choose to focus on the health system, but it's all about looking at how to promote and ensure good governance across the entirety of the county. The report that they released this year or this week for Alameda Health System reflects ongoing discussions between our system and with the Alameda County leadership, both the Board of Supervisors and the administration, regarding significant structural financial issues that face Alameda Health System. We appreciate the work of the grand jury in furthering or further elevating the challenges that we face at Alameda Health System. But rest assured that we are all engaged with the county, or well engaged with our board and with the county, to determine how we can collaborate further to find solutions. We will be issuing a formal response to the civil grand jury report in the coming months as we explore it and discuss it further. Now I want to turn a little bit to the budget. Speaking of finances, our internal team is moving forward with developing our FY21 budget. Those of you who are veterans of the organization know that we operate on a fiscal year basis. We go from July to June. So usually around this time of the year, we will be finalizing the budget. We have a board meeting on tomorrow where that budget would normally have been finalized. Because of some of the challenges that we are seeing with our budget, including obviously some of the recent revelations or recent challenges arising around the pandemic, what has happened thus far, what might happen in the months to come, we're taking a bit of a slow walk or a different approach to the budget this year. We are endeavoring to try to produce a interim budget for our board at the end of July, so about a month from now, and then a final budget in the fall, targeting the September-October window. In light of this situation, there will be some tough choices that we have to make as an organization, and we've talked about a little of that progressively on these weekly calls. We welcome the engagement at all levels of the organization to look at both expenses and revenue to achieve a balanced operating budget for our organization. We're approaching this work with a focus on maintaining the quality of care that we offer in the organization, mitigating the impacts on jobs. Our board said to us in the finance committee recently that their number one priority is to preserve jobs. And while they recognize that there are tough calls that they as a board will have to make, with advice and guidance from us as a leadership, they would love for us to present opportunities that look at a number of things that may be around jobs or around payroll or around benefits, but they would prefer as best as possible to preserve services and to preserve jobs. So there are a number of things that we are considering, some on the revenue side to be sure, but there are also things on the expense management side that we're including for both payroll or considering both for payroll and non-payroll purposes. On the payroll side, some of those things include things like cost of living adjustments that we do on an annual basis and whether we will be able to continue that into this year or have to modify that in some way, as well as PTO or other benefits that we have to consider as well. So just a heads up, nothing definitive at this point, but these are all areas, including obviously, as I mentioned, non-payroll areas where we're managing our supply chain, we're managing the cost of those things, negotiating better rates for things that we have to procure, also better rates for payments from health plans and other services that we're ensuring that we're optimizing our investment in our EHR and other tools that we have for the organization. There will be more information to come on this process, but please make sure that in your areas, if you are aware of or you have ideas for how we can continue to improve as an organization and things that we could do in that respect, reach out to your managers and please make sure that they have heard your opportunities, your ideas, and we can address any concerns or questions that you may have as well. We now turn to our restoration efforts. I'm happy to say that our restoration plans continue to move forward across the organization. As you know, last week we were able to restore elective services in ambulatory, in dental, in outpatient rehabilitation services, as well as perioperative care across our system. We actually heard an update today from our perioperative services, which are largely positive that things are going well. A few snags in the road, but we're working through those and I look forward to continuing to advance in that area. This week, we're reviewing plans in a couple of other areas, including food and nutritional services, interventional radiology and interventional cardiology, and GI. I'm happy to report that on Monday, the Oversight Committee approved the restoration plans for interventional radiology and interventional cardiology, and those should be back up and going, if not by today, relatively soon now. We will continue to closely monitor our key indicators that are driving our ability to restore services while ensuring the safety of our staff and our patients. To remind you, those key indicators include the availability and the use of things like personal protective equipment, or PPE, supplies, and staffing. And we're also keeping an eye on a number of COVID-related hospitalizations, both within AHS and across our local market. It's also important that we understand that the safety of our staff and patients is always our top priority. And if changes in any of those indicators alter our ability to deliver elective services safely, then many of the approved plans may be either amended or restoration of hold-offs on some of those services may be delayed or maybe re-implemented, I should say. It's critical that departments continue to use their daily management meetings and their huddles, also a tool of communication that's worked quite well for all of us, to conduct those real-time assessments of supplies, including PPEs, and to escalate any issues that are forthcoming. We continue to manage our supply, usage, and procurement of our PPEs across the system. Fortunately, we remain out of the red for all of the supplies that are presented on our dashboard, and we're updating that supply dashboard every Tuesday on the restoration and recovery page, and you're able to see that. We show you and include a link in our 3 times a week updates that are still coming out. Now, with respect to masking and screening, as the state and the county began to reopen outdoor museums, outdoor restaurant dining, outdoor fitness, malls, and religious and cultural services, the potential for exposure does increase. Even though restrictions are easing, COVID-19 is still spreading in our communities, and Alameda County continues to have the highest numbers of COVID-19 cases in the Bay Area. I can't express this enough. It is critical that we continue to follow safety protocols to protect ourselves and others from COVID-19. Until we have a vaccine or herd immunity or some combination thereof, we are not free from COVID-19 and escalations of cases. Potential exposure is very real, and every day we see the number of cases rise. Please continue to follow masking guidelines to protect yourself, your coworkers, and our community. Keep 6 feet of distance between you and others. Remind you to wear your mask. We do both of those things in Alameda Health System and across all of our sites, particularly in our healthcare facilities, our public areas, and our shared workspaces. I heard reports, and I appreciate people sharing that there were some areas where this was happening a little bit less or less reliably, and I appreciate that leaders are on top of it today, and I know that we'll see improvements in those areas. But I want to thank all of you for continuing to monitor yourselves and monitor others and remind people of the importance of public health measures to protect each other. I wear a mask to protect you, you wear a mask to protect me. We both wear masks to protect our patients, our coworkers, our families, and other loved ones. Physicians and staff should continue to enter through designated screening entrances or get screened at inpatient nursing units and ambulatory clinics. Now, finally, for testing, excited to say that our testing continues to be offered at AHS for our patients, both at San Leandro Hospital and at the Highland Hospital's HCP parking garage. And we've actually seen noticeable increases in our testing at both of those sites as we continue to expand our testing criteria and our availability of testing in those areas. We also have, and I'm happy to have Dr. Valerie Ng here with us, now new expanded testing capabilities from a laboratory perspective in-house, and we will avail ourselves of that amazing resource, as well as continue to use resources available to us in the community. AHS patients who meet the criteria, including those without symptoms, are receiving tests, and AHS doctors' orders or other providers are made through calling our ambulatory call center or entering orders in Epic, and also through speaking to the nurses in our call center. With that, I will pause and I will turn it over to Terry, and we will go into our Q&A and learn a lot from, I'm sure, our panel here. So, Terry?
Thank you, Delvecchio, for those remarks. There's been a lot of conversation around our restoration efforts. I know a lot has been done in our ambulatory setting, so I'd wonder if, Pallav, you can maybe give us a sense of how things are going. What are you noticing with patients and others in terms of reopening those important services in our system?
Thanks, Terry. Can everyone hear me okay? Perfect. So, reopening, although that's the term we're using, we never really closed. So as all of you know, our clinics remained open during shelter in place. We were obviously only seeing those patients who were urgently ill and otherwise would have needed to go to the emergency room if we weren't open. And so certainly what we've seen over the last 2 weeks is that we're seeing more patients in person than we were before. So through the shelter in place, about 80 to 90% of our visits were done via telehealth, whether that's telephone or video visits, and about 10 to 20% were being done in person. Now those numbers are starting to creep up. So it varies by service line, but about 20 to 30% of our visits are in person, and the rest are still being done via telehealth. So a few just observations. One is it's clear that telehealth is here to stay. It's the right thing for our patients, many of whom are frail, immunosuppressed, are high risk, and as we see the cases rising, in the county and in the state, definitely are not comfortable coming in for services that we can adequately provide over the phone or video. And so we are excited that we continue to refine and improve our telehealth capacity. We're going to be launching the next expansion of our video visits that hopefully we start to get to a point where every patient gets to choose whether they want a video or phone visit with us, whatever works best for them and their condition. And then there's also legislation, Terry, that you can speak to where advocates are trying to, make sure that we get reimbursement for telehealth permanently, even after the immediate emergency is over. And that is definitely the right thing to do for our patients. For the in-person visits, as the numbers are increasing, we are certainly refining all of our safety measures to make sure that we can keep first and foremost our staff and providers, but also our patients safe. We've had a few incidents of patients who tested positive and had the opportunity to test out our contact tracing workflows. We are doing mock drills at some of our sites to make sure that all of our staff and providers feel comfortable with our COVID positive workflows if we need to see a patient who does have COVID-19 and we know about it in our clinic. So Eastmont, huge kudos to them, the Wellness Center. They've been doing mock drills and really helping to streamline the process. So lots of great work going on as we start to recover and a lot of learnings. I think just the two things that are worth mentioning in addition are that we know there's a backlog of patients. So during shelter in place, our demand went down, patients weren't seeking care, and now that it's clear that a lot of people who delayed their care by weeks or months are eager. And so our wait times are starting to creep up, and we're monitoring that closely in the clinics and trying to figure out how we adjust and maintain access, especially for that bolus of patients who've just been waiting for us to reopen. And I know many of the other services are also struggling with that. But things are going, well overall. Guidance also continues to change. So as we get new guidance from the CDC and public health, we're having to continuously refine what our standard practice is in ambulatory. But that's been our experience throughout this pandemic. Nothing is the same from day to day.
All right, Pallav, thank you very much. The testing, who we test, where we test, can't be done without the support of the folks in our lab. So Valerie, maybe you can talk a little bit about how the lab is stepping up to help support that process as we're expanding our testing of our patients at our two sites and in other ways.
Thank you, Terry. Alameda and San Leandro, I know you've been waiting overnight for your results. We promised a 12-hour turnaround time. We are doing the inaugural run this afternoon. I know there's confusion. I know I've heard a lot from various folks about too many tests and not clear what to do. I want to say we have basically 3 tests available to you. We have the rapid test, swab only. That's all you should get. Give me back the swab. We have our new in-house tests for all inpatients. It's halogic, has the high yuck factor, the single swab for the throat and both noses. I'm already getting a lot of pushback on it, but that's the way it is. That's for all inpatients, San Leandro, Alameda, Highland. And then for the SNFs and urgent care employee health testing, we are sticking with the Abbott collection kit. It's the NP swab brain biopsy equivalent. So we have 3 test options, the rapid, which is a 1-hour turnaround time, but we know it lacks in detecting positives. It only finds half of them. We have the 12-hour test. We'll do it twice a day. And then we have the test that is not time sensitive through the public health lab and pretty much restricted for the drive-throughs, pre-op, I'm looking at Felicia, and for the SNFs and for employee health.
All right. Thank you, Valerie, for the first time on the show. That was very that was very cool how you had visual aids and everything as you were giving your questions, and you're up for that. So that's excellent work on that. Thank you so much. You mentioned we're doing more internally. How's our work with the county going? Are we seeing how are they able to process tests? Is anything new happening in that regard?
Yeah, thank you for asking. Excellent question. The ever-changing guidances around testing at the SNFs have tipped the public health lab beyond capacity. When Parkbridge, South Shore, all the employees, and then all the county SNFs and long-term facilities are looking to the public health lab for testing. So ironically, and the reason why we came up with our in-house test is the county asked us to take back our testing volume to free them up to do more testing from the county. And in concert with that, Tangerine is leading a group with Felicia and Lab, trying to put together a response to a county request for, quote, RFQ, for us to provide testing for the county so they can offload their county lab onto us. We are trying mightily hard. If you read my memo update that I sent out a couple of days ago, the thing we have to be careful for and caused a lot of excitement, the two collection kits are not interchangeable. So if by mistake we get the county kit stuck on our instrument, we have the potential to generate cyanide gas. So I've asked the emergency department to be on alert. If the lab people show up, we smell like bleach, and we're losing consciousness and having seizure, please keep cyanide on the differential. It's okay. We got risk mitigation in the lab, but it's just something else we got to worry about.
All right. I don't know if that's an HR issue, Tony, or not, but I do have an HR question for you.
Okay, thank you.
We do have, I don't have to tell you this, a lot of bargaining units that we're continuing to negotiate with in the process. How are we managing those interactions with some of the challenges reflected by social distancing, physical distancing, utilization of Zoom and other mechanisms? How's bargaining going in general in terms of staying on track with our negotiations?
Thanks, Terry. It's a great question. Initially, we slowed down bargaining. The unions, I won't say distracted, but had other concerns. As did we. We were focused on getting ready for COVID and a surge, and so were the unions. They did external work politically and with their members to arrange for masks and other things to be shipped around the country. Since then, we've re-engaged with all our unions, and we have ongoing negotiations. Today, we have bargaining with CNA, and we have bargaining with CNA again on Wednesday of this week. We're negotiating at San Leandro today, and then Alameda on Wednesday, I believe. We have a session set up with the general unit and the nursing unit of SEIU 1021, and we're in negotiations with a number of other different units throughout the organization. They're predominantly through Zoom. We have offered the option that we'll find a large room where we can socially distance, or we'll have to conduct them over Zoom, whichever is the preference of the union. So we want to accommodate where we can, ensure that we progress bargaining, and that COVID, because we don't know how long this is going to stretch on. Obviously, we have a number of contracts that are out. We want to reach agreement on those contracts with the unions, and so it's better that we proceed with bargaining now, and the unions have been amenable to that. We don't have as many sessions as we had prior to COVID, and we are pushing to have as many sessions as we possibly can get in per week with each of those bargaining units. So they are moving forward, agreements are being reached, and we're continuing the dialogue with all of our bargaining units that we're negotiating with currently.
Great. Thank you, Tony. We've talked a lot about the relaxation of some of the shelter-in-place rules, the opening of businesses, and there appears to be some growing concern around the level of which things are reopening, and we're getting more tests, we're getting more positive tests. There is some increase in hospitalizations, particularly in Southern California. As we're looking at restoration, how are we prepared to respond if at some point we have a need to address a COVID-19 surge, particularly in relationship to our opening processes and just our ability to take care of those patients as they present? So Janet, I'm looking at you. I didn't call your name, but you probably felt me giving you the eyeball. Can you give us some thoughts on how we might handle a reversion to, I guess, more stringent shelter-in-place activities?
So I just trying to tease out the question in your statement, Terry. So are you asking if we started to see a surge or an uptick, how we would respond to that?
Yes.
Okay. So thank you. I somewhere got lost in that translation. I think that's something that we all monitor very closely. That is really a primary focus of the Restoration Committee, to be able to vet the plans and processes, and everyone who has presented in front of that committee has very strong processes in place to monitor that. So we have a number of reports that are completed every day that go to the county, the board, the executive committee, where we are tracking to see, how many patients are we seeing that are PUIs, patients that are actually testing positive, knowing that we're doing more tests, so we're probably going to get greater results. And also, what is the acuity of those patients? And so all of that is being put into a blender, if you will, and we're teasing out, are we seeing an increase that would make us kind of sit back and think, do we need to do something differently? Should we see a surge, I think the first thing that would happen is we would stand the command center back up in a formal way, and then start to look at, how do we partner with the county? What are we starting to see? And then do we, start to scale back certain services or all services in a way that we did when we first started with the pandemic? So, just to reassure everyone, it is being very closely monitored, and that we do have plans to stand up the command center at the drop of a hat, and we would move forward from there. I think we're also seeing that there is an outbreak or a bit of a uptick at some of the jails, and so we are being communicated with from them to start to see if we can take their patients. What does that look like? How many can we take? How do we kind of share that? This would be very similar, I think, if we saw an outbreak at a nursing home. How do we start to become nimble and respond to those needs, so that we could take those patients and help in the community? So we are on top of all of that. That is a huge focus for everyone. And I just, really want to reiterate that people need to be assured that we are watching this at all time, and we're prepared to respond to that.
Great. Thank you, Janet. Deveka, you talked a little bit about the budget earlier. I'm wondering if you can share any particular ideas or concepts we're looking at from a budget perspective that might be brought forward in recent or upcoming weeks as we finalize our budget proposal for next year.
Sure, I can, and Tony, if you have others, I'm trying to think of who else is on the oversight committee who might be on the call, or other leaders too, if you know. So we are, as I referenced one or two of them in my remarks. So we are negotiating rates with some of our health plans. So one of the things that we are actively doing now is looking at past experience with some of the rates and performances against what our own expenses are, and working closely with internal teams as well as an external team, depending on whether they are a Medicaid plan or our managed care plans, to look at rate negotiations. So that's one big thing that we are doing. We're continuing to monitor things that are happening with respect to the county's budget and the state budget, and what implications those may have for programs that we rely on to reimburse us for services that we render to the community. So the state budget or agreement was just reached, I think, on Tuesday morning it was, or Monday morning, one of the two, and there were some really big risk for cuts that could have impacted Medicaid programs and services that are considered sometimes discretionary, but for you and I, we would not consider them discretionary. So this is things like ophthalmology and dentistry and other services that are clearly important to everyone, especially the community we serve. And so we were happy to see that the state was able to broker a solution that didn't result in the curtailing or the defunding of these services. And so now we're hopeful that and optimistic we'll be able to continue them. We'll be able to get rates that support those services and there. We're also looking at ways in which we can continue trajectories of things that we've already started that are in recognition of services that we need in our community, like oncological services, chemotherapeutic services, and expanding on investments that we've made to improve the provider staffing there and the access to care within our system. So we're looking at that. We're looking at opportunities to secure philanthropic dollars that would help with some services, including wraparound services in our organization and the like. So a lot on the revenue side. On the expense side, as I mentioned, we're always looking at ways in which we can negotiate rates with vendors and distributors and suppliers to say, can we get to a more economical or sustainable price point with some of the things we're doing? Are there opportunities for us to streamline what we're doing in terms of the number of different types of things we procure in a certain area? So like, implantables or surgical instrumentation, things like that, that if we standardize more and have more economies of scale, we may be able to save money in spaces like that. On the salary side, both for employed and contracted entities, we still, while I'm happy to say we're finalizing the last stages of our consolidation of the Oak Care Medical Group into Alameda Health Partners, and effectively will be East Bay Medical Group as of July 1st. So a lot of our physicians are either employed directly through the organization or under this wholly owned subsidiary, but we also still contract with large groups like UCSF and AIM and Traditions Behavioral Health and others. And with those contracted relationships, we've been looking at, are there ways in which we can sustain or keep costs from growing or escalating more than we can sustain? And similarly, on the payroll side, we're doing the same thing. Are there ways in which we can keep cost living adjustments, or we're exploring either through that or potentially even with our labor partners, cost of living adjustments flat, and or adjust benefits in certain ways that again are all geared at preserving services, caring for our community with an eye towards equity and making sure that we know that those things don't come lightly to individuals. Cost of living are tough, and people's families are challenged with a lot of different things, some losing jobs, some furloughed, some otherwise impacted. And we are part of the ecosystem, and so we're not immune from those things. But as much as possible, we're trying to make sure that we both scale our services and make them sustainable so that we can continue to support the community. So those are a couple of examples of things that we're looking at. The last thing I would say is more broadly just an effort to source ideas from all of you. So if you see some things that we're doing, you're like, I wonder how much this costs. You talk to your leaders, talk to your managers and say, I toss half of these, a month, and maybe we could figure out a better way to streamline our processes so that doesn't happen. Because as our board members like to say, hundreds of dollars add up to thousands of dollars, add up to hundreds of thousands, adds up to millions. And so I don't want to be coy about it at all. We have several $1 million of gaps that we're trying to close, as we tend to do, so not uncommon, but fairly substantial for our organization, but every little bit helps. So thank you for that, and I hope that answered the question.
Okay. Tony, anything you might want to add in that regard?
Yeah, I thanks, Terry, and thanks, Delvecchio. I think it's important for all of our employees to know that as we've engaged in this discussion, the emphasis from Delvecchio, the Budget Oversight Committee, and from the board is preservation of services, as Delvecchio said, and preservation of jobs. That in likelihood is going to mean we're going to have to tighten our belts. We're looking at PTO plans, and we're looking at the cost of living increases for our employees. We're not looking at those things lightly. We're looking at things where we can have the minimal impact to employees. And while those have substantial impact to all of us, the alternatives are less palatable because they impact patient care and they impact people's jobs. I don't want anyone to think that we take this discussion lightly. The discussions are serious. They're measured, they're thoughtful about preserving all of our services and preserving as many jobs, if not all the jobs, that are possible. As I look around the Bay Area and talk to other hospitals on a fairly regular basis, other hospitals are in the same position we are. We are not unique. And so we suffer the same cash shortfalls that they're facing because of reductions in services being provided, and that impacts our revenue. Delvecchio outlined that we're looking at increasing our revenue, but we have to look at the other side of it, which is our cost, and we're going to do so in the best way possible that really considers our employees. And I would be hopeful that, as Delvecchio said, if people have thoughts and ideas about reducing our expenses, we are open to any and all of them. We think our employees have great ideas. The more they share with us, the greater opportunity we have to act on them. So I just want people to know we're very measured in our approach. Nobody's rushing into decisions, and it's very much focused first on patient care and employees And that is really everything that we're thinking about as we go through this process.
Thank you, Tony and Delvecchio. Delvecchio and Felicia, I know you guys have been touring some of the community testing sites. Would love to know what you're learning from those visits. Anything unique pop out at you that is sort of informing our work as we look at our testing? I know there was a visit to Allen Temple a couple days ago. What'd you see? What'd you find? What can you share?
Sure, I'll start. So I've had the pleasure of going to see the Roots Clinic, the testing site at the West Oakland Health Center, and I've also, as Terry noted, been to the Allen Temple. Some of these visits I've been able to go with Delvecchio and with Dr. Gupta as well. And really what has been great to see is that some of our processes that we've been using at our testing sites at Highland and San Leandro really are consistent with some of the practices at the other sites. And so it feels great to be in step with other colleagues in the testing space around processes just like registration, how we collect the specimens, and then a follow-up process. Of course, we need to use some of these learnings because these other sites are operating in the community testing space, and we're looking at expanding into that space as well. We have processes that are for our AHS patients that are working very well, but really, how do we take it to the next level? And these are the processes that have been really helpful to look at those sites, both with just things that you might think are minor, but really are huge, which is around traffic management, path of travel as people coming into the different sites, but also the follow-up program as well. Because if any person that comes and get tested at HS, and especially if they're positive, we need a robust program for being able to reach out to that individual, provide education in terms of what it means to isolate for how many days, et cetera. And so those are all the things that I've been taking away. And really, it's I more than anything else, I find it completely inspiring to see these community centers who are really serving our community here in Alameda County, and specifically the sites we've been to have been in Oakland, and I cannot wait for us to be able to start filling that space too.
I not much to add, except I appreciate them letting me tag along, actually. But it's been, I echo all those sentiments. You know, some interesting things that folks on the call might be you know, as interested to hear as we did is while there's definitely been variability in people's ability to stand these sites up and be able to robustly serve the community in partnership with, and I think all but one, as we visit them, we're doing it in partnership with some third-party entity in the community, but there have been varying experiences with those third-party entities, including the one that no longer works with one. And so while they were, you know, it was open or is open and serving a lot of people, sometimes the reach of those entities are not necessarily congruent with the surrounding community. So they're having more of the individuals and some of those sites come from outside communities, which is great, and we think it's good that people should get tested, but it's not always internally consistent with the goal of putting the testing in the community that we want, so that we're achieving equity and achieving access to those exact populations where the testing sites are. So people are being very thoughtful about that. They're seeing what's happening and trying to calibrate in real time to make that happen. And so in some respects, while progressively doing better in some more than others in terms of reaching the immediate community, struggling with some of the same considerations that we are in terms of how do we make sure that the resources are getting to the individuals that we are worried may not be having access. And the last thing I would add to that too is just hearing some concerns around what we're seeing too in terms of the volume of individuals, or I should say the ethnic makeup of individuals who are actually getting tests too. So some of the statewide data, and others can correct me if I get this wrong here, I think on a macro level, we've heard that a lot of there's a disproportionate number of individuals in our Latinx communities that are testing positive relative to the broader community. And that disparity in terms of actual hospitalizations and deaths exists within the African American community. Part of the disparity in terms of testing in the African American community has been the number of people actually getting tests. And so there's a lot of thought into how many or what may be some either psychological or physical, real barriers to access or testing that aren't necessarily access driven in this case, because some of the sites have capacity. There may be some concerns, real legitimate concerns that people have with if I get the test, part of the testing instructions are about self-quarantining and trying to avoid groups, and that may then impact people's ability to go to work and provide for them families. So real legitimate concerns that cut both ways that I think from a cultural, a socioeconomic perspective we have to think about. And Dr. Sherabina will echo or corroborate this. Even at one site, we heard that there were concerns that they were hearing from people in the community around real paranoia around what was happening truly with the test. Which is kind of a sad indictment of the world, I think, that we're in now, that some people thought that, these tests were covert ways for the government to implant devices in them. And so people were avoiding taking the test because they just weren't clear about, what the truth was. So it's really, really sad, particularly when that type of thing might result in further disenfranchising communities that we are absolutely trying to support with science and evidence and access in these very, very important ways. So I think really, really important learning lessons, in addition to logistics and other stuff that we've been learning from other people as well. But I'm excited that we are pressing forward. And I know that we're looking at varying ways that we can do that at sites, including down at Newark, Hayward, Eastmont, in addition to what we already have.
Great. Thank you both. Valerie, a couple questions for you. The first one is, are we seeing any reinfections of COVID-19?
Thank you, Terry. Travis, you asked this question. I'm going to geek out on the audience to determine whether or not you're reinfected. And we had a huge conversation around a patient yesterday where we were considering this. What that would involve is having the viruses at different times of detection and actually sequencing them to see if there is a difference, mutations, or differences, so that we can say convincingly, this strain is different than this strain. We don't have that right now. We also don't know how to interpret the opposite. If we sequence them both and they have the same sequence, we don't know whether or not a person can get reinfected with the same virus over time, especially if that virus is circulating in the community. So I would just simply say we don't know. And I personally watch the UCSF research website. They are conducting some of those studies. It's good research.
All right, thank you. We have a somewhat unique population of patients at John George. How are we doing conducting testing of them?
I can take this one.
Thank you.
So there's a few different streams. So we have gotten some requests from some entities that we send our patients to from John George to test prior to entry into those facilities. And so we are doing some testing on that small population of patients for some of those post-discharge facilities for John George. While I can't speak to the exact room where where the testing are occurring at John George, I do know that we are following our usual standards, which are that if you're testing an asymptomatic individual, or really any individual for COVID, then you are in a face shield, you're in an N95, and you're in contact precautions with the gown, and you have gloves on for doing the test itself. And we are maintaining those standards across AHS. Now, what we're looking at, and we continue to work through how this will occur, is the process of testing patients who will be going to John George. And we've been working with Dr. Siddhartha, Paula Austin-Gandhari, and then of course our ED leaders across the system, as well as Dr. Ng, around what that looks like, where the testing would occur. And of course, we would want the more rapid turnaround time test that we now have that Hologic. Yeah, Dr. Ng is holding up her specimen collection kit. And we will likely be looking at launching that sometime in the coming weeks. One of the key items that we need to do prior to stepping forward with the more widespread surveillance testing, either in our acutes or at John George, is really working on some items within Sapphire to make it very clear around why an order is being, why a test is being ordered. Is it being ordered for surveillance, or is it being ordered because I'm a PUI? And we want to make that very clear so that any staff member who's interacting with the patient, whether it's within the EHR or entering into a patient's environment, knows why why a test is pending, because of course we want to mitigate any sort of risk. And so we're working on that process with our colleagues in Sapphire to make that clear. So that was a little bit of a deviation of the answer, but it's related to processes that we are putting in place for John George.
Tanvir and Janet and Delvecchia, you're all on the rock looking at different restoration plans that are going out. We received at least a preliminary plan from Food and Nutritional Services earlier this week. And there's a question about distancing in terms of people eating lunch together and those sorts of things. Can you share a little bit about, one, what folks should be doing, and what may be some of the things that the Food and Nutrition Services folks offered up as some options they were thinking about in terms of helping people be able to enjoy their lunch, but at the same time maintaining safe physical distancing from each other?
So I'll start that, and then I'll rely on the team to jump in. So first and foremost, obviously, we want everyone to maintain social distancing. So, you know, good hand hygiene, wearing a mask, social distancing, that hasn't changed. There is a desire to look at different break rooms. Some of the break rooms, for example, at Alameda and San Leandro are really tiny. So when you get 3 or 4 people on a break at the same time, it's not conducive to social distancing. So the weather's been nice. A lot of people have gone outside, but it does rain. It gets too hot. It's not always what people want to be outside. So we're looking at, you know, opening up the cafeterias. How do we put measures in place that people, you know, do hand washing before they go in, they make sure they're masking when they're not eating. We set the cafeteria up so that we have social distancing, you know, move furniture around so that people are able to maintain that. So those are some of the initial ideas. They have a really cool salad robot that they have at Highland that, you know, dispenses it without anybody touching it. So they're looking at different ways to prepare food, provide food, dispense food with as minimal touch as possible. So Tanvir or Delvecchia, do you want to comment a little bit about anything different? But, you know, first and foremost, social distancing needs to be maintained whether you're eating or not. But anything more to add?
I think you covered it all quite nicely. I don't have anything. Thank you. Terry, you're on mute.
Yes, sorry about that. So we're currently doing testing at San Leandro Hospital, HCP, here at Highland. Any plans for testing at our wellness centers in the future?
Sure, I'll take that. So right now we are working with the county, Alameda County, and in fact are still waiting for them to get back to us, because we would like to have some community testing available at the Newark Wellness Center. How many days that will be and for how long is TBD, depending on the need of South County, and we're working with the county on that, as well as the leaders at Newark Wellness, Dr. Epen and Michelle Vanessa. So that is our current plan in terms of expansion to the wellness centers. We do not have any immediate plans to expand into other wellness centers right now, but of course, this continues to evolve on a week-by-week basis. So in the immediate term, we're really we're looking at where are we going to stand up our sites for community testing? Are we going to expand our existing ones or go into a new space? We're waiting for some feedback for the county about Newark Wellness, and then we're waiting on any further expansion at the wellness centers for now.
I'm just going to piggyback on that in case it's not obvious, which it may not be for people who aren't spending hours and hours per week thinking about testing. It is clear that we do not want to do any testing inside any of our facilities because it's an aerosolizing procedure in order to ensure the safety of our staff who are actually swabbing the patients, as well as other patients who may come into that room afterwards. You know, once you swab someone, you have to leave the room completely empty for a long time. That quickly eats up, you know, a number of exam rooms and testing sites. And so best practice, not just at our system, but throughout the state and nationwide, is that all COVID testing sites should really be an outdoor site. And that's a limiting factor. We know at Hayward and Eastmont, you know, we don't own the parking lot. How you set it up, how you rope off space requires a lot of partnership. And I'm definitely grateful to all of Dr. Tornabene's work in partnering with the county to think about how we can bring those outdoor testing sites closer to our patients.
Great, thank you for that information. Very helpful to kind of understand how our processes are working. So Delvecchio, you requested that folks send you some shout outs. I think we've gotten a few. Would you like to shout out?
You want to tell me who they are?
Well, sure, I can do that for you.
All right.
Well, one first shout out went to actually, Tony, you get appreciation from this, is from the folks in employee health who are doing a robust job of getting, handling, you know, TB tests and other things as folks are streaming in to get that work done. So kudos to your team in that regard. So, then there was, and Val, you may know this person, but that mention this person specifically.
Casey, it's Casey. Yay, Casey. Sorry.
All right. Yay, Casey.
We're going to get Dr. Ng out of the lab a little bit more frequently from now on. We can work on that for the wellness program.
She's been spending too much time with those swab collection kits over there.
Cyanide.
And I think there's also a shout out to the post-acute team who received 0 deficiencies for the CDP8 on-site COVID survey yesterday.
That's right. For all 3 sites, I believe, actually. Way to go. That was amazing, actually, because that has not been true for a lot of these skilled nursing facilities around the state. There have been a couple who have had some significant findings. And not only did we not have any findings, that team, the staff there, everyone, they were quite laudatory of the great work we're doing there to keep patients and staff safe. So big shout out to that group.
All right. Well, I was glad to see that the shout outs have now morphed into a group effort. It worked very well. So thank you everybody for kicking in and participating on that.
I love it. And I hope this isn't self-serving. I'll add one other, since we just came off of Sunday, all the fathers out there.
Oh.
Did we get a shout out for Mother's Day when that
happened? I thought
happened?
somebody might say that. Okay, so fathers and children of fathers and mothers.
Nice recovery, Doug.
We did actually run a story on the intranet on Mother's Day and have a video from one of our employees. So
that's true. That's true. Wait, why didn't we do that for Father's Day?
There was a significant social media push out there as well. So thank you, Tony, for attention.
Thank you.
But I always like to say every day is Mother's Day. I'll just leave it at that.
Oh my.
If you would like to wrap us up here as we
I think it's time to wrap up. Listen, as usual, I so appreciate having our panelists here to provide their rich insights and perspectives and information to all of us. So I want to thank all of you as usual and really appreciate it. And obviously, very, very importantly, to thank all of you, because we're here because you're tuning in, you are sharing your questions, you are fueling the dialogue, and hopefully you are getting the responses to the questions that you have. Certainly, you can always reach out to me. You can reach out to Terry and others if there are other questions you have, but we want to keep this going. We want to make sure it's a good use of your time and that you're getting some value from it. As usual, I want to end by reminding you to take care of yourself. It's incredible to think how drastically COVID-19 has changed our lives in only 6 months, and I know this has been a stressful time, including a host of other things for all of us. And so, fortunately, there are steps that we can take to cope, and I want to share those with you. Just a few here. Remember to take care of your body. Take deep breaths, stretch, and/or meditate. Try to eat healthily. I could use some work here. Well-balanced meals, exercise regularly, and get plenty of sleep. Make time to unwind and reflect on the fact that the pandemic will eventually come to an end. It will eventually. Limit the amount of time you spend watching, reading, and listening to news stories about COVID-19, which can be upsetting, unsettling. Certainly want to stay aware, but let's not let that pull you into a negative or counterproductive space. Instead, try to connect with others. Use technology like this for game nights, watching your favorite television shows with friends, socially distance meal times and all that stuff. And please do not be afraid to ask for help. Share your concerns about how you're feeling with a friend or with a family member. Don't hesitate to reach out to your managers, coworkers, or leadership team. We are here to support you during these challenging times. And also, don't forget to check out the Wellness Wednesday messages on our intranet. Today's message talks about the power of wonder and 6 ways to find awe in your everyday life. I'll end with something I shared on the ambulatory town hall today, which is I really want to thank you all for the gift of all the conversations that are happening across the organization and the encouragements around leaning into structural racism, leaning into conversations around diversity and inclusion and health equity in our organization, and continuing to push that we can do more, we should do more, we will do more to move our organization forward and to move our community forward. And that takes partnership and collaboration with everyone here. And as I said to that group, it's somewhat understandable that those conversations can be uncomfortable at this point, but if we keep having them and we keep showing progress and intent and a shared sense of progress in this area and commitment in this area, they won't be uncomfortable going forward. We'll be celebrating what we've done for each other. We'll be celebrating what we've done for the community we serve. So thank you for doing that. Keep it up. I want to thank you for joining us today. I appreciate your participation as always. I look forward to our next chat. Stay safe, stay healthy, and I'll see you next week. All right.